Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone, and welcome to PYA's Summer CPE Symposium, Hot Topics in Healthcare, Day 1. I'm Catherine Good, a principal in PYA's Audit and Assurance Department, and on behalf of PYA, I'm pleased to welcome you to our 4th annual Summer CPE Symposium. PYA is happy to present these complimentary virtual learning opportunities for healthcare colleagues across the country. Over 2 days, PYA thought leaders will present 4 sessions on trending topics and provide key takeaways and helpful tools for you and your organizations. With that, I'm going to hand it over to our moderator.
Our first presentation of the day is 5 months in, taking stock of the Trump administration's impact on healthcare, presented by Martie and Matt Stuart.
Hey, thanks, Jennifer. Good morning, everyone. Thank you for joining us today. It is day 149 of the Trump administration, and certainly it has been an administration impactful on the healthcare industry. And selecting the specific topics we were going to cover was a bit of a challenge, but we narrowed it down to this list of 7. And as you can tell, the first 3 are all focused on the reconciliation bill, named the One Big Beautiful Bill Act, or as I like to refer to it, OBBBA. We're going to provide an overview of what's going on with the reconciliation bill. We're going to drill down on healthcare-related provisions. Matt is going to take us through tax provisions in the bill, and I will highlight then off OBBBA, we will move on to a look at the president's proposed 2026 budget for HHS and the potential impact it would have on providers. We will give a preview of the annual Medicare payment rules, focus in on government enforcement activity, and then very bravely get out our crystal ball and give you some educated guesses of where we see the next 5 months of the Trump administration heading. So starting out with an OBBBA overview. OBBBA is the reconciliation bill. And this is the one opportunity an administration has to address mandatory spending. The distinction in the federal budget is that mandatory spending are those expenditures that are dictated by statute. And it requires that the legislature, the Congress, go in and amend the statute to change how payments are made. This is Social Security, Medicare, Medicaid, SNAP, and several other smaller programs. Discretionary spending, by comparison, are the annual appropriations that Congress goes through, and that funds the various departments of the federal government. So the reconciliation bill addresses mandatory spending, and it is truly the tax and spend bill. Why it's critical is that under Senate rules, the reconciliation bill can pass with 50 votes. Most other legislation, with again a few minor exceptions, is going to require 60 votes in the Senate to end debate, and they're effectively requiring 60 votes for any legislation to pass. But the reconciliation bill is different, again, because it's 50 votes to pass. And so, of course, it is in the interest of the majority to load up as much as they can in the reconciliation bill and take advantage of that opportunity. And so that's where we get with the One Big Beautiful Bill Act, is this reconciliation bill. The version of this bill with which we're now working is the one that the House voted in favor of by 1 vote on May 22nd. The bill is now in the Senate, working its way through. We'll talk about where that process is, but let's talk about the stuff that's actually on paper right now, which is the 1,118 pages of OBBBA. And it really divides into 4 parts. There's the tax cuts and credits component, there's new spending, there's spending reductions, and then what's not on the slide here, which is the debt ceiling provision. And under the tax cuts and credits, the provisions added together equal about $3.7 trillion in revenue reduction over 10 years. Typically, when we're speaking about the impact of reconciliation bills, we talk about it over a decade. So 3.7 trillion revenue reduction over that 10-year period. That's a combination of continuations of the tax cuts that were part of the Tax Cuts and Job Act of 2017 in the first Trump administration, as well as some new tax reductions. And then on the other side, this includes repeals of certain tax credits and the imposition of certain new taxes, which actually generate revenue to offset some of those other tax cuts. On the new spending side, we have about $321 billion in new expenditures, which focus on immigration enforcement, as well as expansion of defense spending. And then number 3 is the spending reductions. That's are intended to offset the loss of revenue. Those spending reductions in the House bill total about $1.57 trillion. As you can see, the majority of that is made up by Medicaid cuts, and we'll discuss those in more detail soon. Then finally, again, what's not on the slide is the debt ceiling increase. In the House bill, we would raise the debt ceiling up to $4 trillion, and that is intended to prevent the United States from defaulting on the loans it has to support the federal deficit expenditures. What's important is that let's talk about what's the overall impact of this bill, and we really look to the Congressional Budget Office score. The numbers you see here on the screen are from the score that was released by CBO on June, let me make sure I got the date right here, on June 4. And this is the straight up impact on the federal revenues. So this is just looking at how much does it increase spending, how much does it decrease revenue. And that analysis, CBO concluded that the bill would increase the federal deficit by $2.4 trillion, again, over that 10-year period. You have to, of course, consider then the debt service that is involved as well. Now, in this score, the CBO was not looking at macroeconomic effects. It was just looking at what does this do to the federal deficit. And the response to the CBO score when it came out on June 4 from the Trump administration was that you have to, in fact, look at the positive effects this would have on the economy and the impact those economic growth would have then would wipe out any negative budget deficit impact of the bill. So yesterday, and of course at 5 o'clock yesterday, CBO released its macroeconomic analysis of the bill. This is a report that it generates in conjunction with the Joint Committee on Taxation. The JCT, I have to say the acronym right there, is responsible for really analyzing the tax implications of the bill. CBO is much more on the spending side, but together they join forces for purposes of presenting this macroeconomic analysis. That report concluded that the bill would generate 0.5% growth in the economy. That would be primarily front-loaded in the first 2 years of the bill. And that, in fact, would result in an $85 billion primary budget deficit. It would reduce the primary budget deficit by $85 billion. However, and it's a big however, when one takes into effect the impact on interest rates, the debt service that's required, CBO and the Joint Committee on Taxation conclude that the impact of the bill is $2.8 trillion increase in the deficit. So relatively small economic growth, $85 billion, does in fact help on the primary deficit, which is just expenditures versus revenue. But when you take into consideration the overall impact as a component of the federal deficit, the result is the bill has a price tag of a $2.8 trillion increase in the federal deficit. That's the report that came out on June 17. Now, in between the two, on June 4, again, CMS published in response to inquiries from Democrats on the House Energy and Commerce Committee what the anticipated impacts would be of the bill on the number of uninsured. How many people are going to lose health insurance under this bill? And CBO calculated that the Medicaid cuts would generate a loss of about 7.8 million individuals. They would become uninsured. CBO notes, and it's important to note, that 1.4 million of those individuals would be undocumented immigrants who would no longer be covered by state plans. So it's very clear federal Medicaid dollars cannot be spent on services furnished to undocumented immigrants. So what 14 states and the District of Columbia have done is create their own state-funded plan that covers services for pregnant women and children who are undocumented immigrants. There are provisions in OBBBA that would effectively cut state federal spending, so that the dollars the federal government provides to states to run the Medicaid program, in those states that have these state-funded plans, the federal government would significantly reduce the overall money that it's giving to the states. So it's a pretty big stick for these states to discontinue these state-funded plans for undocumented pregnant women and children. And so CBO, assumes that about 1.4 million undocumented immigrants would lose coverage as a result of that. In addition, you have to look at the cuts and tax changes impacting the ACA exchanges, folks that get their insurance through the exchanges. The CBO says that's another 3.6 million losing coverage. And then the provision that's not in the bill, the expiration of the existing expanded premium tax credits that they started with COVID, they were continued, but they are set to expire at the end of this year. OBBBA does not include an expansion of those premium tax credits, and thus, as a result of the sunset of those tax credits, CBO estimates 4.2 million individuals become uninsured. So that's how we get to our 15.6 million, that increase in the number of uninsureds. As I said, we've now moved our way over to the Senate to consider this legislation. Again, it's a different story, that there are a different set of political considerations in play. We had on Tuesday. Yesterday was Tuesday. Monday, I'm going to say it one more time. Monday afternoon, the Senate Finance Committee released its draft of the bill, and specifically focusing on the tax provisions and the Medicaid provisions, because those are in the purview of the Senate Finance Committee. And they have made some significant changes. Matt will go into those in greater detail. What had been discussed that we were sort of anticipating was some changes in Medicare Advantage to generate cost savings. Those were not included in the Senate Finance Committee. So there's those political discussions going on. There's also this thing called the Byrd bath. Byrd is a reference to the former senator from the state of West Virginia, Robert Byrd, who was sort of the master of the Senate rules for many, many years. But these are the requirements that all provisions of the bill have to comply with the reconciliation rules. And so the Senate parliamentarian is responsible for reviewing the bill and identifying provisions that have to come out. And that is an ongoing process. The House, in fact, has already agreed to certain changes based on the initial parliamentarian reviews, but this will continue. The other interesting piece of this that has to be navigated is sequestration. Because CBO reported that because of the budgetary impacts of the bill, that kicks in the statutory pay-as-you-go provisions, which require under statute that when there's a certain increase in the deficit as a result of legislation, there are automatic reductions in mandatory spending. And specifically in the context of Medicare, That includes payments that are made to providers, MA plans, and prescription drug plans. This is the 2% sequestration that we have been living with now since the Budget Control Act of 2007. And it will continue on, given now into 2032. CBO tells us because of the provisions in OBBBA, we would have to increase the sequestration amount from 2% up to 4% as a result of this. Now, Congress has the authority to avoid this by introducing subsequent legislation. It can't be part of the reconciliation bill. It has to be subsequent to the reconciliation bill that simply takes these expenditures off the books. And we did that. I mean, we did that with the job cuts, the Tax Cut and Jobs Act. I always get it wrong. I apologize for that. And then the Inflation Reduction Act, same thing. The difference is when you do that, when you take it off, that's going to require 60 votes. And so there's some political maneuvering that could occur there, but it's something of which certainly to keep your eye on going forward. So with that gets us to polling question number 1. Jennifer, over to you.
All right. The first question is, do you believe that the Senate and House will reach an agreement on OBBBA before the July 4th holiday? Yes, no, I never try to predict what will happen in DC. Remember, you must fill out the polling questions in order to receive CPE credit. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
Well, you don't seem to have a lot of faith in Congress to get the job done. Only 11% of you expect this bill to be signed by our nation's 249th birthday. But it's an even split between those who say no and those who wisely never predict what's going on in DC. At least I keep trying to learn that lesson. Let's delve into the healthcare-related provisions of OBBBA. Specifically, let's look at Medicaid. The big issue here is this new national work requirement. We've had 2 states, Arkansas and Georgia, that have previously implemented approved work requirements, but this would now add an across-the-board work requirement. It would be effective at the end of 2026, and it would require states to condition Medicaid eligibility on individuals between the ages of 19 and 64, either work or participate in some qualifying activity for at least 80 hours a month. And there are exceptions, of course, for individuals that are disabled and parents who are taking care of dependents. States, however, would be required to verify both prior to enrollment and then every 6 months that the individual meet these requirements. And so sometimes you will hear work requirements referred to as red tape requirements because of this constant monitoring and reporting process that is required. OBBBA, in its current form, the House form, does exclude parents with dependent children. The Senate Finance Committee print, which I referenced previously that came out on Monday, would limit that to individuals with dependent children who are under age 14. So this, again, expands out the work requirement. OBBBA requires the issuance of guidance from CMS regarding work requirements by the end of this year, 2025. Notice the word guidance, not regulations, guidance. Remember, regulations are subject to notice and comment. But this is setting up that we're going to get rules of the road, shall we say, for work requirements as opposed to formal regulations. Next up, under the Medicaid changes in OBBBA is the delayed in implementation of the eligibility and enrollment final rule. This was a Biden administration rule that was intended to simplify and ease enrollment in the Medicaid program. Under the bill, the implementation of those rules will be delayed through 2035. And then new requirements for expansion states, they would have to redetermine eligibility every 6 months for the expansion population. Current rule is a year, so these would become more frequent under the new rule. Probably the provision that is of most direct concern to providers are the changes in the rules regarding Medicaid provider taxes and state-directed payments. These provider taxes, just highly summarized, they are state-imposed taxes on certain categories of providers. They are used to generate revenue. The state uses that revenue then to draw down additional federal matching funds. The rule for Medicaid is for dollars spent by the state, the federal government will match that based on an FMAP. And that's the percentage that's calculated of how much, every dollar is matched by the federal government. And then what states do when they have these provider taxes and they have this additional revenue, right, because they're going to get more federal revenue in, they'll use that then to expand provider reimbursement. And in last few years, beginning in the first Trump administration, continuing through the Biden administration, CMS has allowed allowed states to use provider taxes and state-directed payments to bring certain provider rates up to average commercial rate, or ACR. ACR is almost always higher than even Medicare rates, so it's been a significant boost in revenue for a number of hospitals. Under OBBBA, states would be prohibited from establishing any new provider taxes or increasing their existing rate of taxes. So it's a freeze. In the expansion states, they would be prohibited from adopting any new state-directed payments for hospitals and nursing facilities that would exceed Medicare rates. So no more ACR. You're going to be capped at Medicare rates. Non-expansion states would be able to go up to 110% of Medicare. Very important, in the current House bill, there are grandfathering provisions. So it would protect all current state-directed payments as well as those that are currently pending with CMS. And there are a number of states that are in that boat right now. It's Illinois, Nebraska, by way of two examples, are waiting for approval of their provider tax and state-directed payment. Under the House bill, those would, in fact, be allowed to move forward. So then we fast forward to June 6th. When there was a presidential memorandum issue that's entitled Eliminating Waste, Fraud, and Abuse in the Medicaid Program. And this memorandum particularly targets Medicaid payment rates that are higher than Medicare. And it is directing HHS to take appropriate action to ensure that states do not have Medicaid payment rates that are in excess of Medicare. Again, targeting these average commercial rates. Obviously caused concern because there's no provision in the presidential memorandum, at least, regarding grandfathering. What we do know that there is, as of June 9, a proposed rule sitting at OMB for review that's entitled Medicaid Managed Care State-Directed Payments. We don't have a text of that proposed rule. We will receive that once OMB finishes its clearance. But wait, there's more on this subject. We now go to the Senate Finance Committee, the bill text that was released on Monday, and it's a whopper. The hospitals did not see this one coming because the Senate Finance Committee would call for state-directed payments to be reduced. Currently the cap for state-directed payments sits at 6%. They would reduce that by 5% every year between 2027 and 2031. That would effectively reduce the cap from 6% of provider revenue down to 3.5%. And almost all states have provider taxes that are in excess of 3.5%. So every state would have the process of figuring what to do with that loss of Medicaid revenue. Then, insult to injury, there would be a requirement to reduce existing state-directed payments by 10% each year, beginning in 2027, until they are the equivalent of Medicare rates, or 110% of Medicare in non-expansion states. So everyone with ACR who thought they were going to be grandfathered, nope. Every year starting 2027, those go down by 10% until you're finally at the Medicare rate. So it's a big hit. Particularly this is focused specifically on hospitals. I should have made that clear. This reduction in SDPs does not impact nursing facilities, but it's a significant piece of a significant chunk coming from hospitals. And we do not have a CBO score on the Senate Finance Committee provisions yet, but certainly it would be negative for hospitals. You see here the existing analysis of where the Medicaid cuts, how much revenue how much savings they generate. You see it's primarily coming from the work requirements, the eligibility rule, and again, provider taxes. That number obviously is going to go up significantly when you took into consideration the current Senate Finance Committee view. Other Medicaid provisions of which you should pay attention to and about includes retroactive coverage. States are allowed to permit providers to recover costs going back 90 days from when an individual qualifies for Medicare. That would now be reduced to 30. There'd be new rules regarding cost sharing for individuals in the expansion population. There would be new requirements on states to track enrollee contact information to prevent dead people from receiving Medicare or individuals receiving Medicaid in 2 states. New provider screening requirements that would be applicable to the states. Very concerning is the erroneous Medicaid payment provision. This wouldn't kick into FY 2030, but CMS would begin reducing the FMAP percentage for those states that are identified as having excessive payment error rates. So the expectation here is this is going to generate a lot more Medicaid-based audits going forward. And then you also see other provisions listed there that relate to Medicaid. Appreciate that while the impacts are significant, when CBO talks about 15 million people losing coverage, that is not even across states. And those who are in expansion states are going to be more significantly impacted than folks that are in the non-expansion states with regard to the decrease in the number of enrollees in Medicaid. Let's also focus here on the ACA marketplace. Again, remember that was about another 3 million people losing their health insurance. Or actually 7 million when you include the non-renewal of premium tax credits. What the legislation would do is shorten the enrollment period from 3 months to 2. It would also eliminate special enrollment periods. So if you lost your job and you need to go get insurance, you've been able to claim a special enrollment period under the exchanges, that would go away. You'd only be able to enroll during those 2 months designated as the enrollment period. They would eliminate passive re-enrollment, so you have to re-go up every year to get your exchange coverage, and they tighten verification requirements. And so that's how you get to that increase in the number of uninsureds. Key provisions in OBBA concerning employee health benefits. Interesting topic here to impact providers, but it's going to have impacts on coverage. The choice arrangements are those that would allow employers to make tax-free contributions to employees to allow them to buy product on the exchange. So rather than having their own, going to Blue Cross Blue Shield and buying a contract of insurance for their employees, they instead would allow employees to go purchase on the individual markets. Also changes to health savings accounts, broadening out that folks could use their FSA account for direct primary care arrangements, pay the subscription fees on DPCs, as well as fitness and exercise programs, allowing seniors to make contributions to SSAs, and then also increasing the limits for individuals earning less than $75,000. Interestingly, the Senate Finance Committee bill text eliminates all of these provisions regarding HSAs. On the Medicare physician fee schedule, it just keeps coming, doesn't it? Current law, as you're familiar with under MACRA, the payment rate for providers is based on the weight of RVUs assigned to that particular service times a conversion factor. Legislation determines what the conversion factor is. And for 2025, the base adjustment was 0 by MACRA, and it will continue. It will be 0 for 2025. In 2026, it would go up to 0.75% for individuals participating in advanced alternative payment models, 0.25% for everyone else, including for hospital services that are reimbursed on the Medicare physician fee schedule. Lots of complaints about this. Last year, we saw about a 2.9% decrease in the conversion factor due to budget neutrality adjustments. OBBA would change the rules. It would provide in 2026 for an increase in the conversion factor equal to 75% of the MEI. That's Medicare Economic Index. That would be estimated to be a 2.25% increase over 2025. So it doesn't even make up for the cut in 2025. But then going forward, the annual adjustment would be based on 10% of MEI. For example, in 2024, the MEI had been 3.5%. In that case, the increase under the budget would have been 0.35%. Still have the budget neutrality provisions, no changes to MIPS, but that's the solution that's being offered in this legislation with regard to physician fee schedule. That gets us to the second polling question, Jennifer.
Thank you. The second question is, do you believe OBBA's change to Medicare physician payments are adequate? Yes, no, or I need more information. Remember, you must fill out the polling questions to receive CPE credit. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
I'm with the 50.96% that need more information, because these provisions in OBBA are pretty slim. Certainly, we need to see how that would be developed out by regulation by CMS, but certainly stay tuned on this particular issue. That brings us to some good news under OBBA, what there is. The legislation would delay Medicaid DSH reductions, which are slated to be $8 billion a year for 4 years. Those would be delayed through 2028. We've been kicking that can down the road since 2014. Let's just keep going. It would prohibit HHS from enforcing the nursing home minimum staffing rules that have been promulgated during the Biden administration. It would also provide some changes to enrollment for out-of-state pediatric providers and impose some new prescription drug pricing rules for pharmacy benefit managers. Very complex provisions. Just give you a heads up that those are in OBBA as well. That brings us to the fun stuff, Matt. Let's talk tax.
Yeah, thank you, Marty. Yes, appreciate everybody's time this morning. And yeah, let's spend a few minutes talking about some of the potential tax provisions here in the One Big Beautiful Bill Act. So quickly, before we get started, just wanted to give a shameless plug that tomorrow, several of my PYA tax colleagues will be doing a more in-depth dive of some of these tax provisions and applicable planning considerations. So just wanted to tease that as we go through here. This is kind of the high level, greatest hits, if you will, of the tax provisions. But certainly Joe and team will be diving more into those tomorrow. So just to get started here, the first one up is individual tax rates. One of the things that is proposed in the bill is that it makes permanent the Tax Cut and Jobs Act, the lower tax rates. Those rates were scheduled to increase this year back up to the higher tax brackets that they were historically. However, that would make those lower tax brackets from 10% up to 37% permanent. It would also permanently increase the standard deduction that was part of the Tax Cuts and Jobs Act. If you filed your taxes in the last few years, you notice that the standard deduction has become a lot more lucrative or beneficial, I guess I should say, than it was in the past when it was, not as hard a decision to decide between whether you itemize or do the standard deduction. Another item that's in here is SALT, or state and local taxes. It would increase the cap on the state and local taxes from $10,000 to $40,000. So if you live in a state with higher taxes, that would obviously be beneficial to you because you'd be able to deduct more on your federal return due to the state taxes. The Senate version of this that came out a couple of days ago does eliminate that increase. So it'll be interesting to see how the House and the Senate reconcile those, if it stays at 10,000 or if it goes up to 40,000 or if they meet somewhere in the middle. Another change is with the child tax credit. It increases the current credit of $2,000 up to $2,500 through 2028. And then it reverts back to $2,000. But then from that point forward, it would be indexed for inflation on an annual basis. And then the Senate version would just increase the child tax credit to $2,200 permanently and then index it for inflation going forward. All right, so this next one up here, if there are any heirs and heiresses on the call, this one is for you guys. It would permanently extend the exemptions for estate and gift taxes to $15 million for single filers and $30 million for married filers indexed for inflation. So good for you guys that are in that camp. The next item is one you've probably heard about on the news, but it would make tax-free tips and overtime income through 2028. The Senate version would impose some limits on the amount of the deduction. So again, House version is anything this tips or overtime is tax-free. The Senate version would put some caps on there. So again, they'll plan to meet in the middle, I'm sure, on that. The next one up are what's being known as MAGA or Trump accounts. I've been advised not to try to do my Trump impression here, so I will spare you all that. But if you want to imagine this in Trump's voice as I talk, let your imagination run wild here. But it would be a tax advantage savings account for children with $1,000 of federal seed money. It would be for those children born between 2024 and 2028. The purpose of these accounts would be to be more broader based than some of the accounts that are currently available. So, for example, like a 529 account is limited for education expenses. This would be not be able to be withdrawn by the participant until the child is 18, but it can be used for more options like a down payment on a house and things like that. Some other items in here are a senior standard deduction increase. You can see the amounts there. Car loan interest deduction through 2028 and more. So just a couple of impacts on hospitals and health systems. Of course, Marty's done a fabulous job covering a lot of those already, but just a couple that are very tax specific that I wanted to mention in here. It would increase the executive compensation excise tax. So currently, if you're a not-for-profit organization and you have employees that are earning over $1 million annually, the previous law applies just to the top 5 highest paid employees. OBBA would expand that to all employees earning over $1 million at your organization. It does maintain, however, the exemption for if you're providing medical care. So we do think that if that stands, that physicians earning over $1 million would be exempt. However, any executives or other employees earning over $1 million, even outside of the top 5, would fall into that category. And then the next one up here is one that I'm sure is near and dear to everybody's hearts. If you remember from 2000, the Affordable Care Act, but this was part of that was originally struck down in 2019, but it's the parking tax. It has made a reappearance in this bill. So again, we'll see if it stands in this bill or if it gets removed, but it has reared its head again. So, and with that, I believe that takes us to our third and final polling question, Jennifer.
All right. The third question is, do you support the tax provision changes in the OBBA? Yes, no, yes, but only because I do not want to pay extra taxes on my $100 million inheritance. Remember, you must fill out the polling questions to receive CPE credit. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
Thank you, everybody, for filling out this poll. I had no idea. So 26% of you all are set to inherit over $100 million. So if you'll send Marty and I at the conclusion of this presentation, your social security numbers, addresses, will become best friends. No, I'm kidding. Yes, it sounds like it's, in all seriousness, looks like it's a fairly even split between those who are in favor and those who are not. So with that, Marty, I will turn it back over to you. Let's see, Marty, I think you may be muted.
Yeah, I'm sorry about that. Well, enough. Let's talk about other things that are going on in Washington. And again, we discussed previously, the reconciliation bill deals with mandatory spending, but we've also got this annual appropriations process that we have to start. And we have not really done an annual appropriations process since 2022. Because for every year since then, we've simply had a continuing resolution that adopts the prior year's budget with some minor modifications. But hopefully this year, we will actually have Congress do its job and go through the budgets for each of the departments and determine the appropriate appropriations for those. So this process begins with the president releasing his budget. There was a first version of this that came out in May called the skinny budget, which provided a general outline of what the different department budgets would look like. But on May 30, we got the much more detailed budgets, including the budget for HHS. And what we found there was, again, consistent with the skinny budget, but also consistent with a lot that had been announced by DOGE through the early spring. So the budget, the HHS would have a discretionary budget, no impact on payments under Medicare and Medicaid because those are mandatory, but HHS discretionary budget would be $95 billion, which is 25% less than its FY 2025 funding. They intend to reduce the workforce down to 90% of pre-COVID levels and want to reduce, and most of that, those reductions in staff, they claim are coming from reductions in centralized administrative functions. So duplicative, press offices or the like. They would be eliminating those and thus reducing workforce. Also, under the budget, they would terminate, de-scope, or not renew about 5,000 contracts that providers currently have. Not providers, but the different vendors have with HHS. HSS would be consolidating their 28 operating divisions down to 15 and shutting down operations in the most expensive 5 regional offices. We get to keep ours in Kansas City, apparently because we have relatively lower rent, or some other reason beyond that. Also key to this budget is the new Administration for a Healthy America, AHA, as we call it now. This is the functionality within HHS that will be focusing on prevention of chronic disease, do broadband technology integration, nutrition services, physical activities, and reducing medication dependency. So all of those priorities that RFK Jr. has identified all sort of roll up into AHA. And in fact, several federal agencies, those operating divisions and agencies that would be consolidated, many now are finding their way to AHA. That includes, for example, Health Resources and Services Administration, HRSA. They would roll into AHA. The budget then allocated for their services are down about 18%. That's concerning in particular because HRSA is the agency or the functionality, which will now be at AHA, that's responsible for community health centers or FQHCs. And so there is some impact there negatively. Also, for rural providers, this is the loss of the Flex program. Is included in that cut as well. So those extra dollars that have been going to rural hospitals to support them in education and quality improvement, those are wiped out of the budget here. You can see the other reductions to the different agencies, how they fall out. I want to call your attention specifically to the CMS. The CMS budget is a 16% cut, which is relatively light compared to other agencies for their administrative expenditures. But in particular, I've got concerns about a 30% reduction in the amounts paid under contract to the Medicare administrative contractors. The MACs are the folks that receive claims, pay claims, enroll providers, provide education, all of that work that they do across the U.S. CMS says we're going to reduce those budgets by 30%. And they claim that's appropriate in that we're going to de-scope some responsibilities and we expect them to be more efficient in their processing of claims. So I think that's very concerning for providers, given how dependent we are on MACs to do their job, and something certainly worth watching carefully moving forward. Next up, let's talk about the annual Medicare payment rules. This process we go through every year to get the different Medicare programs funded. And this is a status report. We start with Medicare Advantage because that's always the first of the rules that we run through. So we're looking at the plan year 2026 rules have now been finalized. Those rules provide for about a 5% increase in payment rates to Medicare Advantage plans. That increase is due to the increase in traditional Medicare utilization, particularly in Q4 of 2024. Yes, you heard me right, that Medicare Advantage plans receive more money when utilization in traditional Medicare goes up. That's what the statute tells us. One of the reasons we were looking at whether changes in payments to Medicare Advantage would be included in the Senate Finance Bill, but we're going to continue under that model, at least going forward for now. There were also published by the Biden administration in late December the policy rules that impact Medicare Advantage plans. So how, in fact, the plan's behavior is regulated. Back in 2024, we had a number of new rules regarding the use of prior authorization by MA plans, for example. There were additional expansions on those restrictions included in the proposed rule, but the Trump administration chose not to finalize those provisions. In terms of proposed rules that have been published, we have the Hospital Inpatient Prospective Payment System proposed rule that came out in April. It provides for a 2.4% increase in payment rates based on estimated cost increases. Remember, payments made to providers are adjusted based on estimated increase in the cost of delivering services. And so CMS formula based on that statutory provision say they need about a 2.4% increase. We are now waiting with bated breath the publication of the rest of the proposed rules, particularly Medicare physician fee schedule and hospital outpatient prospective payment system. Those typically show up as our Independence Day presents. So we'll start looking at those probably next week into the second week in July. We expect those all to be published. Certainly we are, gearing up for detailed webinars running through those proposed provisions. Let's talk next about government enforcement activity, what we've been seeing and what have been the signals under the Trump administration. And that starts with what we're some concern about there being a new sheriff in town. We've had historically, we've watched what OIG is doing, we'll watch what DOJ is doing, but it appears within CMS, we're going to have a new fraud fighting entity, specifically known as the Fraud Detection Operations Center. CMS has announced that we're going to concentrate within the Fraud Detection Operations Center a number of capabilities to do not only pay and chase as we know it today, but also identify fraudulent payments fraudulent claims before any payment has been made. Particular focus on the use of AI to accomplish that. The goal set for the Fraud Detection Operations Center is to generate $40 billion a year in recoveries. Appreciate that in 2024, that amount was 10 billion. So we are kind of looking on the edge of a 4-time increase in enforcement activity based on those estimates. So certainly CMS is well aware of the fact that for every dollar they spend on enforcement, they get a $10 to $11 return. And so this is a wise investment, even when you're cutting other federal programs. Other note of concern is there been chatter among CMS folks, sort of in podcasts and public presentations and the like, of an interest in being more aggressive in the use of payment suspensions. So this means when CMS or one of the MACs identifies what look like potentially fraudulent claims, they will suspend payments, and not just payments on those claims. They suspend payments to that provider, all of their payments. Having lived through some of these payment suspensions, 1 or 2 of them in the past, they're incredibly damaging to the organization because there's no money coming in from Medicare. And really, because it's a fraud investigation, no ability to secure any loans to cover that loss of revenue for a period of time. What it does have the net impact of doing is bringing you to your knees really quickly and finding some solution to those allegations of fraud against the organization. We'll see if it really happens, whether it's maybe just some saber rattling or if it is going to have an effect going forward. Regarding the Department of Justice and white-collar crime, there had been some hope that the Trump administration would back off of white-collar crime prosecution. On May 12, DOJ Criminal Division announced what it was going to be doing going forward, and it said we're going to focus on high-impact areas of healthcare fraud. High-impact areas of white-collar crime only. And what's number 1 on that list of 10? Healthcare fraud. So we can expect that we're going to see some more enforcement activity out of DOJ on that front. We also have a new Deputy Assistant Attorney General in the Civil Division who is responsible for False Claims Act litigation. This individual came out of private practice defending healthcare False Claims Act cases. Are we hopeful that this individual may be more provider friendly, at least in times of the amount of time it takes to review a False Claim Act allegation, how long it takes to get through the settlement process? Maybe we will hopefully will see some improvements there on the fraud criteria. Finally, let's talk about RAD-V audits, an announcement made by CMS a couple weeks back about their plans to eliminate the RAD-V audit backlog. These are audits that CMS does to validate patient diagnoses that are submitted by MA plans, because MA plan payments, their capitated payments, are impacted by risk adjustments. And so risk adjustments are determined by the number of diagnoses that are listed by the MA plan. So the question is, are those diagnosis codes in fact supported by the medical record? MedPAC estimates that MA plans right now are being overpaid to the tune of $43 billion due to overcoding, overclaiming diagnosis codes. So CMS conducts these RAD-V audits to validate those diagnosis codes, but they have a significant backlog. They are going back all the way to 2018 since they've really done any significant backing of that, reducing that backlog. What they intend to do is to get current through 2024 by early 2026. They intend to very much engage with AI to flag unsupported diagnoses. They intend to increase their team of medical coders from 40 to 2,000 by September 1st of this year. I'd love to know where to find more medical coders, but apparently the government's got a good line on hiring several more. They intend to complete plan reviews for all plans. That's about 500 plans, I think. Right now, they do it about on a sample of 60. What's this mean to providers? Certainly, at the end of the day, those diagnosis codes are in your medical records. And so expect that you're going to be getting requests from plans to produce more records. So certainly an administrative burden, but then also what's the potential of recoupment by MA plans based on lack of medical necessity? So if there had been a diagnosis not supported in the medical record, now we have plans recouping dollars because they claim that those services, in fact, were not medically necessary. I guess sort of sharing the pain of these audits over with providers. Last 5 minutes here, let's have some fun. Let's do some guessing on what we think we may be seeing going forward for the next 5 months or to the end of the year for the Trump administration. So looking into our crystal ball, somewhat educated based on statements that have been made by administration officials and others. So number one, no doubt, we're going to see increase in price transparency, penalties, and enforcement activity. There was an executive order issued in February that called for more stringent enforcement and increases in penalties for hospitals that do not comply with price transparency requirements. There are estimates that there's about 30 to 35% of hospitals that are not in compliance with the current version of price transparency today. Certainly an important area for which you should be devoting resources to bring your organization within compliance. I think we'll also see some moves either legislatively or by regulation to increase providers other than hospitals. Specifically ambulatory surgery centers, independent diagnostic testing facilities. Those will probably be the first two that will end up with price transparency requirements as well. We're guessing there's going to be an expansion of the mandatory episodic payment models. You know that beginning January 1st, about 700 hospitals are going to be part of the TEAM model, transforming episodic payment models, which takes several surgical procedures and now makes hospitals responsible for the total cost of care for 30-day period post-discharge. We suspect, given that those are guaranteed wins for CMS because they set what the price is going to be and they get paid back if they're over that price, that we're going to see some expansion of those mandatory episodic payment models. Even some of us betting that when the hospital outpatient rule is published, that TEAM will be extended to all PPS hospitals. We'll see what happens on that one. We're going to expect that somewhere along the way, in all of their discussions, Congress will finally get around to extending the telehealth waivers that we've been operating since the end of the pandemic. Since the beginning of the pandemic, which have allowed the delivery of Medicare beneficiaries telehealth services when they're present in their home, without regard to whether they live in a rural area or whether they're physically present at a facility. So sort of those 1834M requirements for telehealth, we're going to get another waiver through the end of 2026. Congress will not put us out of our misery by simply making those permanent. We expect some congressional action on Medicare Advantage prior authorization requirements. There have been legislation that has been introduced that is getting favorable bipartisan support. That finally Congress, rather than waiting for CMS to issue regulations, will instead take up the cause of reining in use of prior authorization by MA plans. Appreciate that a number of states have been very aggressive on this front. Nebraska, for example, just had a bill signed into law that's very aggressive with regard to the use of prior authorization by all commercial payers. And I think we'll see more of that state level legislation as well. Bad news, I think we're going to see expansion of Medicare site neutral payment policies, either at the legislative level, where Congress says no more enhanced payments for HOPD services that can be delivered in a physician clinic setting, or we're going to see it through regulation by CMS, again, waiting to see that outpatient proposed rule to see if CMS takes some action there. Cuts to Medicare payments for 340B drugs. If you recall, CMS for several years had reduced payments, got taken to court. Supreme Court finally ruled that CMS had not acted appropriately reducing those payments because it had not done a survey. We had an executive order in March directing CMS to do the survey. So likely we'll see those survey results translating into reductions in 340B payments for participating providers. Finally, last but not least, we expect that we will see a final HIPAA security rule published sometimes in 2026. Yes, the comments were due on it back in 2024, but the administration seems very interested in expanding connectivity among providers. Core to that, of course, would be the HIPAA security rule, so expect that final rule. And then we think at some point, CMS will rescind the changes to the HIPAA privacy rule around reproductive rights. Those went into effect, as you know, on December 23rd of 2024. I'm almost surprised we haven't seen this already, but we anticipate that would be happening. Now, our anticipation does not mean it's the case, and certainly you need to continue to comply with those requirements with respect to disclosure of information related to reproductive health. So that's what we think may happen, for what it's worth, but we've made it through an hour sort of talking about all this regulatory stuff. I hope this has been helpful moving forward. But Jennifer, let me turn it back to you for closing comments.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us, and have a great rest of your day.